geriatrician palliative care physician who has extensive experience in geriatric consultation as well as inpatient and outpatient palliative care, including hospice. She's a graduate of Stanford University and received her MD and residency training in internal medicine at University of California, San Francisco. After her geriatrics fellowship at University of North Carolina, Chapel Hill, she practiced in Maine for 20 years before moving to Hawaii with her husband, Steve, who is a gastroenterologist. And I believe the only one on Kauai, right?
Oh, now there's two.
Oh, now there's two, okay. Dr. Coleman is medical director for HMSA's Supportive Care Program, an innovative home-based palliative care benefit for those with serious illness. She speaks nationally on detection, diagnosis, and care for people with dementia. Dr. Coleman served a 4-year term on the National Advisory Council on Alzheimer's Disease for Health and Human Services in Washington, D.C. She was a co-chair of an Institute of Medicine expert group on advanced dementia in 2014. There's a report that was written about that by your co-chair of the committee, and I'll send that to everybody. I'll send everybody a PDF of that wonderful published article on advanced dementia. Laurel is one of the founding members of Dementia Friendly America, the effort to help communities embrace and adapt to the needs of persons with dementia. She was a member of the National Board of Directors of the Alzheimer's Association from 2002 to 2010. So thank you so much. We're so honored to have you here today, Dr. Coleman. Thank you so much. I'm going to start recording right now.
Okay. So nice to meet everybody from a distance. It's a little awkward, as you can imagine, to talk to people you can't see. So I can't get that feedback of what your faces look like. I like giving this talk because I'm very passionate about improving care for people living with dementia. And my hope is that, let's see if my slide advanced.
That down arrow.
Down arrow. Got to push the right button.
Did it move? Oh, maybe side arrow.
Tried that too. Hang on. Slight technical difficulty. Click on the slide, maybe. There you go. Yeah. Had to be off of that. Okay. Oh, here's the sponsored by. Jody did all of this. I could have advanced the slides during this part. I did a very bad Vanna White. Okay, now we're going to get this back on track. So my goals today are to help you understand a little bit more about the course of dementia, to describe how palliative care provides a really unique approach to this type of care, and I think it ends up being a better fit. Talk about the challenges of navigating the healthcare system and how much more difficult it is with this disease process. And then also to encourage you how you might apply this information to where you work and what you do. And I think, not knowing all of you, I think you're touched by this in some way, but you might even ask specific questions at the end about, you know, exactly how to apply some of the stuff in your work area. So briefly, so we're all on the same page, palliative care really focuses, it's really specialized care for people with serious illness, focusing on symptoms, but also on quality of life for the patient and the family and caregivers. It can be applied at any phase of the disease process. This is commonly misunderstood to be hospice care, that's one and the same, but think of palliative care in a broader way, that it goes from the time of, at the beginning of, can go for a time of beginning of a serious illness. And hospice care is really very much, it's still palliative care, but focused only on the last phase of life. So really on the end of that arc. Palliative care can and should be provided simultaneously with any curative or usual treatment. But like hospice, ideally it involves a multidisciplinary team. Not one of us has the answer here. And if you haven't learned that in dementia care, you're going to learn it quick, because it can't be all done by a family, and dementia care can't be all done, taken care of well entirely by a physician or a nurse. We need to work together to provide this kind of care. palliative care is a lot more than pain management, and its focus on advanced care planning and patient preferences is really a hallmark of this type of care, as we'll talk about. Then just through a few good photos throughout the talk. Now we laid the groundwork for palliative care. Let's be sure that we're still on all on the same page in terms of how we define dementia. So dementia is really a group of symptoms that must include some amount of cognitive, especially memory impairment, that affects your thinking and social abilities severely enough to impair your ability to function independently. That ability to function independently is the key factor in a dementia diagnosis. So there are some changes in our memory with aging, with normal aging. There's mild cognitive impairment, but the difference between those and having a dementia diagnosis is with those, you compensate with, you know, if I can't remember my shopping list, if I don't write it down, I remember to write it down so I don't forget, and I keep my function high. But a person with dementia, you begin to see problems with their overall function because they can't compensate for their cognitive problems. Why I bring out this this comment about dementia syndrome, question mark, means that for a long time we've really put nomenclature or words around dementia, dementia being the broad term, but then to say, is this Alzheimer's disease, or is this vascular dementia, or do they have Lewy body dementia, or dementia-associated Parkinson's disease? All of those are real entities, but there is a lot of a lack of clarity in any one person's situation as to the inputs to how their brain functions. So I might see someone who has the features of Alzheimer's disease and no other mitigating circumstances that I know, and then I find out later that they had a head injury when they were younger. Maybe that has contributed to that. Maybe a person drinks alcohol and has been an alcoholic. That is an input. Maybe they have vascular disease that you see in looking at their poor circulation to their legs. Well, that's happening in their brain too. So when you think about it, what you're almost always seeing is some combination of causes in any individual. Our science isn't advanced enough to really, without a doubt, except at autopsy, tell us what those inputs are. So I like to now start using the term dementia syndrome to get away from a misunderstanding that we can be totally accurate at this point in our science. There is no doubt that people with dementia or dementia syndrome, there are a lot of them in the United States. And the estimates are over 5 million now and rising rapidly. But when you look at medical records, probably about half or less have been formally diagnosed. If you take that 5 million and say how many are really in early phase, middle, or advanced, about 2 million people probably have advanced dementia. Again, some of those are hidden to us, but that means they're dependent on others for all of their activities of daily living. And that's a staggering statement when you think about what that means to be a caregiver for someone who needs help with everything. And as far as caregivers go, we know there are more than 15 million Americans that are full or part-time caregivers currently for someone with dementia. So why is dementia unique? So there's a lot of other very important and horrible conditions that don't have cures or effective treatments. I think of ALS as one. There's many more. But what's different about this disease that makes it more challenging? And that is because the person with the illness often loses insight into the disease as it progresses. Now that's even in and of itself a little challenge, because I'll see some people with very early changes that have excellent insight into what's happening, and I'll see the same level of impairment and the person has zero insight. They don't believe they have a problem. So that means, all our processes about support, diagnosis, what you can do, et cetera, it's a completely different ballgame if somebody doesn't believe they have a problem. And that's not as true when you're talking about cancer or heart disease or lung disease. But we do have to remember that over the course of the illness, even somebody who initially has some sense of having a problem will begin to lose that. That insight is a key part. But what does that mean for a caregiver? Well, if a person doesn't know that they have a problem or can't see it or admit it, then that's a harder person to care for. I don't need your help. I can still drive. And this causes greater caregiver burden, greater cost for both formal and informal care. The other really key point, and if I encourage you to remember one thing, that is that the disease over time robs people of insight and ability to participate in their care and their planning. So when we don't elicit preferences and values early, if we can, we miss the opportunity to get that, to really get the most important input that we can get about how to make decisions for them when they get sicker. So that's why dementia is so remarkably different than other conditions. So us as healthcare providers, and those of you that are in the audience as well, I hate to say it, but the research shows that we rarely discuss advanced care planning. We don't do it well with people who are healthy, and we seem to do it not any better even when we know someone has dementia. Why? Well, there's so many, so many reasons, but one, it's hard to do it. It's hard to talk to somebody with early stage disease and not completely discourage them about planning for a future that looks pretty grim. That's a hard conversation. We don't have much time. It's hard to get time with the patient, let alone to find time to speak with caregivers when the patient isn't present. We may be doing a better job, say, disclosing the diagnosis and talking about care in this phase, but it's even more rare when we want to talk about what's going to come and help somebody really peek under the curtain, so to speak, and look ahead to feeding issues and difficulty swallowing, infections, falls, and the more total care that the longer they live with this will bring. And then finally, it's hard to discuss advanced care planning when doctors routinely overestimate prognosis in dementia, and that's been shown in studies where they asked physicians who were admitting people to long-term care, people who had advanced dementia, and they asked the doctors to say, at this point, how long do you think this person has to live? And only about 28% of the time did they guess correctly that the majority of the people in that group had 6 months or less to live. And they guessed it a quarter of the time. So that's pretty bad odds. You could have flipped a coin better than that. So now let's talk about palliative care and why it's a better fit than usual care. And palliative care, remember, can incorporate some aspects of usual care, but with a focus on quality of life and patient preferences. And that's really the laser focus difference about palliative care. So if you think about our medical model and how we usually respond to medical issues, it turns out that multiple myriad of studies shows that we spend a lot of money for usual care, but unfortunately don't get the outcomes that people want or expect, or that the literature says people without dementia get. And we also fail families and patients with their expectations for usual care. So it looks like in advanced dementia that 2/3 to 3/4 of hospitalizations are probably medically unnecessary, meaning they don't achieve the outcome they intended, or they are thought to be discordant with the patient's preferences. What does that mean? If somebody says, I would like to live at home and have my care focused at home, how often do they get sent to emergency rooms or have hospitalizations, which appears to be discordant with their care? So that would be that would have fallen into this category too. A fascinating study about 3-4 years ago showed that pacemakers were placed in persons with dementia, that's what PWD means, at almost twice the rate of patients without dementia. Now that should just, if you haven't heard about this, that should just shock you, because when you think about it, you think there's nothing about dementia that causes heart problems, so there's no reason for pacemakers to be placed more from a physiologic point of view. But what is happening? Well, vague symptoms, for example, like somebody's weak or confused or not eating well, and then somebody finds maybe something slightly, abnormal in their cardiac valve, and they want to jump to, oh, well, maybe a pacemaker will help. Well, in reality, it doesn't help for much of those people, but the patients themselves aren't able to report symptoms well. So, it just seems kind of crazy that people with advancing dementia get an intervention that doesn't help their dementia, much of the time at twice the rate of normal of people without. Survival after hip fracture and pneumonia is very poor in persons with advanced dementia. We'll talk about that again later. About 16 to 20% of people living with dementia ultimately die in the hospital. That's not always a failure on our part or on the family's part, or et cetera, but it largely is considered not the optimal place to die, especially when most people's preferences are to be at home or in a setting of their choice. And then sadly for me, when you look at people with known dementia, they've had it for years, they are approaching the end of their life, their dementia is getting worse. And when they are in a long-term care setting, which in this study was more nursing home care, about 20% had a transition near the end of their life. That means that within the few weeks before they died, they were moved at least one time between the emergency room and the nursing home, or hospitalization, or to a different level of care. And that's clearly not good for someone who's approaching the end of their life. They then become more, unmoored, nothing's familiar, and relationships aren't built by that time. So it's just not ideal. And then finally, research shows that symptom management is generally less effective or less effectively done given for people with dementia. And that hip fracture patients, when looked at between who has dementia and who doesn't with the same hip fracture, it looks like people with dementia get less pain medicine on average. And yet there's nothing about dementia that says that pain is decreased for them. They may not report it as effectively, but this is a myth in terms of comfort and quality of life. So now we're going to start just looking at things a little bit by stage. So very briefly, because we mostly are going to focus on more advanced dementia, but very briefly, when you're talking about early and moderate stage disease, the focus should really be about advanced care planning. Discussing disease progression with the patient when possible, or with the caregiver if the patient's not able and willing to do this. This is a delicate, but it's an honest and important conversation. And you need to build some muscles to do this, and need to figure out as you try it what's helpful, what kind of works. And as somebody who does this a lot, I'm also trying to figure out how this unique person and their personality is going to engage this. I don't do it the same way. Advanced care planning is important. We're going to talk about a new advanced care directive in just a second. But before we talk about that, things I do early and moderate stage is talk with caregivers about the stress of caregiving and who's going to support them, what other supports in the community are available. I speak to both caregivers and the patient about the upcoming challenges with cooking, planning for driving retirement, if that's not already happened, what might happen if people wonder and become confused, and what's happening with finances, because often that is not well appreciated But one of the most damaging things that can happen is somebody either unwittingly gives, loses their money, unwisely invests it, who knows what happens to it, that kind of thing, or they're taken advantage of by people, and that's happening a lot. So I bring that up very early, having a trusted person get permission to help with finances, even to act as a safety net. Person thinks they're doing okay for now, I say, great, let's do that, but let's allow a safety net, because this is a mistake or a problem you don't want to happen in the future. When we talk about goals of care, I asked about what's important to you. What are the most important things to you now as you're getting older? I don't necessarily say, you know, as you're having dementia, what's now important? No, because their life goals and wishes and hopes, you know, didn't really include dementia. I just asked what's important to you. That gets to the definition of quality of life, but I find if you say, what's your definition of quality of life, that kind of is a difficult question. So go to what's important to you. What's the most meaningful for you? If they cite something that I know they won't be able to have forever, like I want to live in my own home by myself and take care of myself till I die, and I know that's unlikely to be possible, then I'll try to turn the conversation to, well, I understand that, but if something happens and you're not able to have that, then what's the next most important thing, or what kind of care would you like? When I can, I'll move the conversation to choices of medications, depending on their answers to those questions. Sometimes the medications are very clear when somebody says, you know, my goal is to live as long as possible. And so that's really clear what you do with the medication list. If for other people it's, I'm fine, I've lived a good life, I'm ready to, you know, go be with my husband, or they're unhappy in some way, well, then that brings up an option to discuss about what medicines are used for and what helps them achieve their goals. Planning for hospitalizations. Most people think that dementia is only a brain disease that affects their thinking and memory, but in reality, as it progresses, as all of you likely know, that computer up there also begins to be affected in terms of their motor system and coordination and balance. So falls, infections, difficulty swallowing, all that will bring up medical problems in the future if somebody lives long enough into the dementia. And then you have the usual things like stroke and heart attacks that, you know, spare no one just because they have other illnesses. So this is an exciting thing, and I put this website, dementia-directive.org, because it's a new special advanced directive form or worksheet, basically. It's not a legal document like a POLST is or a durable power of attorney, but what it does is it really brilliantly, I mean, nothing's perfect, but I like this, and I've been trying to use it in my patients and seeing how it works, but it really brilliantly breaks down dementia into 3 stages: mild, moderate, and advanced. And on each page, the mild page, moderate, advanced, it describes, this is mild dementia, and it describes a few sentences about what that's like. And on moderate, it explains a little more, and on advanced, a little more. And then it said, if you would have mild dementia, as illustrated like this, if that's you, then what would you want your healthcare to be focused on? And here I've given you an example: to live as long as I could, and it describes that. This is exactly from the form. To receive treatments to prolong my life. So if I have mild dementia, do I want treatments to prolong my life? And then numbers 3 and 4, to only receive care in the place where I'm living, or to receive comfort care only. So you put people in the space of, this is mild. And then you turn the page and you go to moderate, and it describes moderate, and you go back and make these same choices. And severe dementia, what does that look like? Needing help with everything, not recognizing your family for the most part, losing ability to speak and to walk, And then it asks these same choices. Now, I find this really powerful for a couple of reasons. If someone, well, many reasons. I get so excited about this, but if you have early stage dementia, you might have the insight and ability to complete this. But it's been a hard discussion to lead them through this, right? And if they want to see it as a theoretical discussion, i.e., well, this is me, but that won't be me, I won't get advanced, that's okay. They can do that, but you're still asking them to make a preference if. In the long shot in their mind that I'll be in that situation, this is what I'd want. And that's so crucial for us, because often if people don't express their preferences while they can, we don't know how to proceed in the disease phases where they're less able to help us, right? And we're leaning back on, well, did your mom say anything about this when she had another friend or a family member who she cared for with this? And we're leaning on things like that. The other thing is, when you think about it, how many of us are going to develop dementia? You know, a lot of us, the longer you live, unless science comes up with something remarkable, many of us are going to get dementia. And maybe by 85 years old, there'll be half of us with it. So I think I could fill this out for myself right now if I had mild dementia. And it makes it kind of less threatening to people, because I could say to a patient, I want you to take this home and talk about it and think about it. And I can say to the daughter, this is a useful thing for you to fill out too. And that kind of takes the stigma away from it, that it's not all about them and their problems. But hey, since we don't know the future, why don't we prepare for this and think about it? Sometimes I use examples of, if somebody says, oh, that's not going to be me, that's not going to happen, and I'll say, well, do you own homeowners insurance that covers a fire in your house? Of course, is the answer generally. And then I say, well, are you hoping for a fire? And they say no. And I say, see, you can plan for something to be wise and put things in order to take care of things without hoping for it to happen. I don't hope you get dementia. You don't hope it. But here it is, just like having homeowners insurance, that kind of so you sort of destigmatize it a bit, this advanced care planning. So I switched the slide to dementia is a terminal illness. No surprise to you, but a lot of people don't realize that it is when it progresses over time, unless you die from something else. And how do you die is that you could die from all the usual things that people die from as they age, or you can die from things that come to you related to the dementia. So things like weight loss and eating problems, recurrent infections, which we don't understand very well as to why people with dementia have increased infections, organ failure. Maybe you don't comply with your medical treatments. You were told to, control your blood sugar and walk more and exercise, but you don't. And therefore your diabetes gets worse faster, and you get heart disease. So that in sort of insidious way that dementia changes you and makes you unaware or less capable to plan and to organize may actually lead to a terminal illness or more illnesses. And even though I say it's a terminal illness, this is a very challenging prognostication situation, because in early and moderate stages of the disease, this disease can last a long time, and yet in some people it doesn't and progresses more rapidly. It doesn't have a common timeline that works the same way in everybody. And remember, when I talked about this being a dementia syndrome, that's because other things are going on in the person to sort of affect, what's going to be their prognosis. So if you have vascular disease in your brain, then goodness, then you might have a faster progression than somebody that has pure Alzheimer's or, other inputs. Even in severe advanced dementia, it is hard to tell when somebody is in their last 6 months of life, and that's our classic hospice criteria, but we know this is incredibly challenging to do well. And sometimes that's because when we think someone's approaching the end of their life and we get them that valuable help from hospice, well, then they change the trajectory, right? By helping to feed, by helping to bathe, by getting medications, by giving the caregiver respite, and all these things that may change the prognosis. That's not a bad thing, it just makes it more challenging. So we're going to just talk a few more about the next stage issues in advancing dementia, ongoing discussions about goals of care. These discussions don't happen one time. They happen over time as things change, right? Over time, we discuss again, hey, now we're in this stage, or now we're faced with these decisions. So we constantly modify. How we treat the other diseases that somebody is dealing with needs to be constantly reevaluated, because sometimes those things cause burden and discomfort. Somebody who used to check their blood sugar all the time and adjust their eating to keep their blood sugar a certain way, well, now is starting to cry or push someone away when they come for a finger stick. Well, that just means that's burdensome to them, and we need to change our approach to that, to honor that. Think about medicines and their different side effects and burdens as disease progresses. We need to have explicit discussions about caregiver burden and its consequences. What started out as a daughter or a niece that was doing fine with this caregiving, as people advance, it becomes much more difficult in some cases and more physical, and the burden takes toll. So we need to realize there are health consequences for them and financial consequences for them, and keep bringing it up in terms of what supports they might need. And, you know, really sometimes you have to dive into discussions about finances and care options, because so many people have had the promise. A daughter might say, but I promised my mom that I would not put her in a nursing home. And we have to really talk about that, because, you know, that's an unfair promise to ask someone, right? Because you don't know what this journey is going to be like, and what the toll on your daughter and her family and her finances, for example. If you did, you might not ask for that promise. So we all do our best. We wish there was more services and supports available, and we need to keep working on that. But I don't know how many times I've had to sort of talk back someone from the edge in terms of, well, I promised this. But really, that's an unfair and very difficult thing to ask of anyone, as you don't know what it will entail through the course. So hospitalizations in advanced dementia are really, I like to use this as the ultimate square peg in a round hole, because there is nothing in a hospital that's designed for a person with dementia. Just think about just getting into your bed, and then they put up the bed rail and they say, you know, hey, don't get up, press this button and call me if you need to go to the bathroom. Well, that's not going to happen, and it's a very confusing environment. So every process in the hospital is almost completely designed as inappropriately as possible for people with dementia. And that, and then add to the fact that delirium is much increased with any illness and change in scenery like hospitalization. This makes it a difficult time. And when I have a chance to do it, I tell families, this is unfortunately not a break for you. This is not a vacation. That your presence there is going to be as big of a factor as the medical care as to whether this person leaves the hospital or dies in the hospital. So let's get family friends in there. Let's take shifts. I'm not saying you have to live there, but we need a constant presence of somebody that's familiar and helpful so that they aren't alone. Unfortunately, people with advanced dementia are hospitalized more than those without dementia, but they have worse outcomes, and we are loath to share our opinions, but we need to do it. So when people think they're going to go in the hospital to have that hip fracture repaired, and person's going to come out and learn to walk again and come back to their previous level of functioning, we need to say things like, you know, in my experience, I've noticed most people don't rebound to their previous level of functioning after a hip fracture or a hospitalization. And, you know, that just sets up the expectation of, oh, then are we doing the right thing with this? Or what other options are there? Or to start that conversation. But the expectation to do perfectly well after a hospitalization is not realistic. This is just a little bit about some studies about the 6-month mortality is greatly increased that they, for hip fracture and pneumonia in people with dementia. And that's not a study where they did anything different. They just looked back in a large hospital system at hip fractures and pneumonias, and about half the study group of those people that had dementia died within 6 months. Of their hospitalization for hip fracture of pneumonia, 50%. That wasn't true for the group that didn't have dementia. So in fact, if you had counseled the family, hey, this is a significant marker for mortality, we will likely see a limited life expectancy after this hospitalization, you know, different choices might have been made. They might have chosen hospice care, for example, instead of that hospitalization. And that hospitals don't really fix the major problem, which is dementia, right? And may worsen outcomes. And families have a hard time hearing this message, but to be fair, we don't really make it easier for them because all paths seem to lead to the hospital. If you are a caregiver and someone's sick, you know, you're calling the primary care doc who may or may not answer. You may not be able to get your mom out of the house to the doctor again because they're feeling sick. And if you don't do that, then they get sicker and you have to call the ambulance. And then that means you're in the emergency room and that means you're in the hospital. And there were not good options for that family. So a healthcare system that doesn't give folks good options other than traditional usual care, then we're at fault too. You know, these aren't lazy caregivers that, you know, cause this, that they really have not easy pathways to get alternative methods of care. Some places have mini hospitals at home and ways to bring services right to someone's home for someone with pneumonia who's short of breath. But you're not going to tell a caregiver, you know, I know she's short of breath and seems to be suffering. Are you sure you want the hospital? And give them no other choices. So we've got to start to provide these options. Almost done here. A couple more slides and then we'll allow for questions. Pain management is really challenging, and you've probably heard talks just on this subject, but very briefly, my tips on this is, you know, you have to rely on dynamic or real-time assessment strategies. No, none of this, how was your pain, or how has your pain been recently? You have to say, how is it now? And what does that mean? That means you have to go assess that pain a lot more often than you do in a person without dementia because you can't rely on their memory. There are lots of things in the literature about scales, and a really important strategy of trying medication rather than, for example, putting someone on a trial where you're doing some scheduled dosing. So the person that's agitated, that seems to be striking out at caregivers, and we've changed the environment, we do this and that. Well, you know, maybe there's arthritis pain that's making them grouchy and they don't know how to express that. Well, so you can start with Tylenol or another low intensity medication and assess the behavior. So that's an important thing to try in some folks, and realizing that people with dementia often get less pain medication for any given disease. Weight loss and eating problems can be very common, but they're hard to predict because some people do the opposite. And I have a patient who eats everything that he can get his hands on and doesn't want to walk or do anything else. So he's going the opposite way. But for many people, a change in the taste of food or difficulty swallowing and weight loss is common. We know that feeding tubes aren't the answer, and I'm not seeing that very much anymore, rarely. It helps that my husband is the doctor on Kauai that puts feeding tubes in, and he checks them all with me beforehand, so that's a good thing. But we can't move from place to place, so that's just only on Kauai. And that we're changing the fact that long-term care facilities used to reward used to be rewarded financially for getting more payment for having people with feeding tubes, so that promoted their use. We do see fevers and infections in advanced dementia more often. Again, this is stuff that's important to mention to families as what to expect, so that they're aware. And then antibiotics are not always the solution for every fever. And we increasingly give more antibiotics in people with advanced dementia, you know, that maybe they're having aspiration, maybe they have other reasons to have fevers, but if we keep giving antibiotics, you know, that just makes more antibiotic resistance, and studies show lots of people die while taking the antibiotics. So that's the clear proof of concept that it's not always fixable with an antibiotic. So you want to anticipate that and talk about the use of antibiotics or not, and what other things we can do that are less burdensome than IVs and shots and, you know, maybe a trial. So we need to design better systems so that hospitalizations aren't the only way that we get care, because when you hospitalize people, they're much more likely to move to long-term care, which is not what people want. We need to break out this problem with the skilled benefit and not being able to get hospice at the same time, design that benefit differently. We need a better structured system for accessing palliative care in nursing homes, in the community, so people get this kind of help with advanced care planning and symptom management, and more options for people, like I said, for caregivers when they only see the emergency room as the only option. So hopefully you see over this talk that palliative care for dementia is a good fit as far as the kind of structure of care, because it's a terminal disease process. Its emphasis on discussing goals and quality of life is a priority through all the stages. And I think when you do that, you're helping caregivers and the person with dementia, if you start early enough, you're helping them make a plan rather than just a reaction to things that happen to them over time that they didn't expect. Our usual medical model is a poor fit for people with dementia. Like I said, you don't get the outcomes that you would expect. People with a hip fracture and dementia don't do as well as people without dementia. So we can't just keep trying to apply the same systems. And then we need better incentives for providers and the community to spend time discussing the important issues. Advanced care planning code for provider reimbursement is helping a little bit, but something like this dementia-specific advanced care planning document, I think, is exciting. And again, more options for promoting palliative care and having system design. So in the absence of a cure, a palliative approach to care can have a significant and profound positive impact, not only on the life of the person with dementia, but for their families and friends, and even for staff and facilities as well. So thanks for the time to talk, and I will let somebody tell me if there are questions.
Yes, there are some questions. Thank you so much. That was brilliant. We do have a question that came in from Jeanette Kojane, who is Executive Director.
She's not allowed to ask questions.
Uh-oh.
No.
She's Executive Director of Kokua Mau. If some of you don't know, it's Hawaii's Hospice and Palliative Care Organization, and that website is www.kokuamau.org, or you can Google Kokua Mau. Jeanette, would you like to ask the question? She was asking something about why isn't the advance directive legal, maybe the one you were referring to. What was your question, Jeanette?
Is it legal? Is it not standard?
Jeanette, I'm trying to find you here.
I think I know what she means. I think I mentioned that it's not a legal document in the same way a living will, verbal power of attorney for healthcare, or a POLST is. And I think, Jeanette, it's just that it's brand new, and much like the early days of other advanced care documents like 5 wishes and things like that. I mean, it's being tested. And could we have a caregiver or a durable power of attorney sign it along with the person or whatever and show it to health? I think it could be, but it's just not set up in the same way at this point that a POLST is. I still think it's really valuable for us to try to begin to use it and consider pushing it along in that process.
So
Thank you.
Can you hear me?
Yes.
Yeah, so thank you, Laurel. This is Jeanette. What I was thinking of doing was putting it out in the Kukuamau newsletter and sending it out to key people and getting people start to talk about it and use it. So any ideas you have on that are good. It seemed like it would just be such a great addition, fitting in with these other free tools that we have, and that starter kit from the Conversation Project for people with dementia, all these things to get people talking. So
Well, no, Jeanette,
that's something I'm thinking of doing, of just putting that out. And since I wrote down that you think it's brilliant, I'm going to quote you. But if you think that's a good idea.
I think it's perfect. I would change a few things, but I think by and large, it's an advance for us in doing advanced care planning, I think. So I printed out 50 of them, and they're free. Anybody can use them, so they don't prohibit you from that off the website, which is nice. So why not do it? I think, what was I going to say? I had another thought about it. Oh, the other thing that I think is brilliant about it, since I said that and you said it, is that I can hand it to a daughter or a son and say, all of us should think about this if we are in this position. And that really sort of de-escalates it as being, this is your problem, you're the one with dementia, what do you want? And it's theoretical enough out there that I think people can engage with it in a more wholehearted way. But anyway, that's what I like too. We should all fill it out, right? Half of us are going to have dementia.
Okay, there is another question here. Good to hear about the Advanced Care Planning Code for provider reimbursement. Can you talk more about this?
This is very much an inside baseball kind of conversation as far as, physician provider coding. So there's a lot written on it. You can look on the internet about that. I would tell you that the downside of using that code, so in other words, I don't have to fit it into my primary care visit within that context and hurry it up. I basically can add, when I use that code, I say me, but anyone, any provider, it allows you to be reimbursed for spending more time on this subject. And that's really important and good, and it's an advance. But the downside is using that code as an add-on code requires them to pay a second copay for the visit. So you almost have to ask, is this worth it to you? I want to be able to do this and spend more time. It will cause you to pay another copay for this visit. Is that okay with you? So if we don't disclose that, then sometimes people are angry. But most of the time, I think whatever the copay is well worth the extra 20, 30, 40 minutes of time that they want to really talk about these tough issues. So,
also another question, how may we utilize the POLST to include the dementia directive?
I'd have to kind of think about this. The POLST is very much, what the POLST is. You don't alter that in any way. It's an importance of medical order, and it has, standing in that sense. So you don't do a lot of writing on a POLST that's not, it's not outside the boxes. I think you could certainly take the dementia directive that someone fills out, and that could inform the filling out of the POLST when you do that. You're seeing the person's preferences, and I think that's probably the way to do it. Is if they're saying, if I look like this, if I have moderate dementia, this is my goals of care, you could then sort of say, okay, mom said that 6 months ago. We're now sitting here doing a pulse for her. Let's make that pulse look like her preferences. And I think that's probably right now the way you would integrate them. And I'd probably, if I was a daughter, I'd probably be showing that form to doctors in hospitals and primary care doctors at some point to say, hey, we did this and I just want you to be aware of this. So,
does anyone else have any questions? You'll have to unmute yourself. We've unmuted all of you over here, but if you're on the phone, I saw that a lot of you were calling in to unmute yourselves if you have a question. Okay, I have a question, Dr. Coleman, about HMSA supportive care program.
Oh.
Could you describe that, and also is dementia one of the could it be one of the criteria for being involved in the program?
Absolutely, great question. So the HMSA supportive care program has been around 3+ years, 4 years, and it is a program that provides home-based palliative care support. So an added level of support for people with serious illness that have HMSA as their insurer. And there's a few plans within HMSA that it's not covered for, but the majority of people in HMSA are covered for this. It is designed for people who, and we'll talk about criteria in a second, who are facing serious illness and showing that they have functional decline, they need more support in their living environment, and they're at risk to need to go back and forth to the hospital because of that functional decline. And they also may need help with advanced care planning and other aspects of just dealing with a serious illness. So it is allowed for up to 90 days, and it's delivered through all our hospices on the islands. Every hospice participates, and it isn't hospice. It is allowing curative or their usual care to go on for the time of the program while getting the support at home like a hospice would provide. But you can keep your doctors, keep your usual care, and then get this additional level of support. The way we do who qualifies is we say that we have qualifying criteria that are just automatic. So people with advanced cancer, and I'm not going to all the inside baseball, but advanced cancer, advanced lung disease, and advanced heart disease. And then and the way you get evaluated to see if you meet the criteria is have someone refer you, your treating physician, or you yourself can call a hospice agency and say, I'm interested in supportive care for someone I'm caring for or for myself. Do I qualify? And they come out and do a visit and evaluate you. The question Jody asked is, can people with dementia access it? And the answer is yes, but it is not an automatic criterion because people with dementia are not easily, you cannot easily tell how ill they are, what their other illnesses are. So for example, someone that has moderate stage dementia and also has heart failure and lung disease, they could be quite ill between that. They may not have to have end stage lung disease and end stage heart disease and end stage dementia, but the combination of illnesses could make them quite good candidates for this help. But it's really hard to use, as we know from hospice, it is hard to prognosticate for a 6-month or less prognosis. And so if you're saying now back it up to people with dementia that's not as severe, can we get them in this program? Well, yeah, but it's even more difficult to prognosticate. So we're really looking for people with combinations of illness, and dementia really is an important factor in overall mortality and disease progression. So they come in under a medical director exception. So I would say, yes, that's fine. We welcome people who need this extra level of support, but they have to have significant morbidity. I'll give you an example. So I got this call that someone from a son who went to a hospice, and, you know, he couldn't leave his mom home alone because her dementia was progressing and he couldn't afford a caregiver, and he wanted this program to come over and be her long-term support while he worked. I completely understand, but that's not what this program is for. She wasn't ill. She didn't have a lot of active treatment or another disease process that was making her more ill, but this is not meant to be a support for our lack of a long-term support for people with dementia. It isn't that, and it's only 90 days. So if you are interested in it, ask a physician or approach your local hospice and ask for an evaluation for the supportive care program.
Thank you. Jeanette, do you want to talk about how they can access the CMS codes on the Cocoa website?
So if people want to know more about these CMS codes, we put together a handout on that reflects also what Dr. Coleman said. So if you, I don't know if you put in CMS codes and Kukuamau, a handout comes up, but there's also other stuff online too, specifically about this. But, you know, we are also trying to make people aware of that.
Thank you. We have a couple of minutes left here if anyone has any questions, more questions. I just have one little question about the use of sitters in hospitals for people with dementia. I think, I may be mistaken, does California require sitters, or do they offer sitters in hospitals? I know that my dad had advanced dementia. He was in the hospital, and his geriatrician at the time recommended a sitter, and it can be helpful, but what have you encountered about that?
Well, I'm not sure about regulations and requirements in different states. There's certainly not a Medicare requirement. It makes sense, and they are utilized extensively in hospital settings when people, especially when they aren't safe, because as soon as you walk out of the room, they get out of bed. We don't want to restrain people. They're agitated. They're, confused, and so that can be helpful. But when you think about it, I mean, it's an unreimbursed expense to the hospital. So, and it's often very hard for them to staff that. And half the time you're seeing someone, on their phone or painting their fingernails, just sitting by the bedside. They didn't ask for this assignment. They don't really like a person with dementia. They don't know them. This person's grouchy. So, yes, they can be helpful, but that's why I would much prefer families and friends who know and love the person to be the person at the bedside to help. But, they're engaged and they have some skin in the game. That said, sitters can be really useful, especially motivated ones, but they are not always available.
Thank you. So anyone else, I guess, thank you. People are thanking you.
You're very welcome.
About the knowing about the advanced directives, and also someone said for 2018 is supportive care offered to EUTF PPO plan members?
Yeah. We got that on, yes, in the last 6 months, an agreement for the EUTF retirees active plan. I think it's just for the retirees, but if you want to send me an email, I'll get that answer for you. Even that was an advance because it had not been included in the UTF. So we'd mostly be targeting for the retirees because they're more than more of those folks are ill. But my email for HMSA is my first name, Laurel, Laurel, and then an underline, and then Coleman, Coleman, @hmsa.com.
Thank you so much.
That's why I have a program manager that works with me. I got to do the medical side, and he does the other side. So anyway, but it is an active Quest members. Our Medicare Advantage program, which is Akamai Advantage, is going to pursue that as a formal benefit for next year. It's offered as a pilot still, so we're including more people.
Thank you. There's a lot of thank yous coming in from people. So thank you so much for your time and being here today. And please, for folks on the phone who didn't see the chat, please email me at jmishan, M-I-S-H-A-N, at hawaii.rr.com, or call me at 808-295-2624 if you want a copy of the slides. I would, and the article on advanced dementia. And again, thank you so very much.
You're welcome.
It was fantastic. I'll stop the recording now.